Good afternoon. We are Monday, February 27, 2023. My name is Dr. Lyne Filiatrault, and I'm a retired emergency physician, and I will be your host today. Protect Our Province BC is a grassroots initiative made up of physicians, nurses, policy analysts, and policy scientists, as well as community advocates. And I am a member of Protect Our Province BC. Our goal is to keep British Columbians safe by providing them with up-to-date information about the state of the COVID-19 pandemic and the latest science. We aim to nudge government to use a science, evidence-based informed approach to the management of the pandemic in British Columbia. And our goal, like everyone else, is to end this pandemic. Before I go further, let's take a moment to acknowledge that our team at Protect Our Province BC is coming to you from the traditional, ancestral, and unceded territory of the Coast Salish peoples, specifically the Squamish, Musqueam, and Tsleil-Waututh. And myself, I am located on the unceded and unsurrendered land of the Alkomilem speaking peoples. We're grateful to the Indigenous peoples who have cared for these lands since time immemorial. We recognize that we are settlers, and we commit to our utmost to uphold the Truth and Reconciliation Commission and to work towards the 94 calls to action. So today, with the rise in hospitalizations starting up again in British Columbia, and Canada, as well as British Columbia, starting to enter a new surge in the pandemic, we thought it was apropos to speak about COVID. So we will focus on three things during this briefing. Number one is, what do we know about Paxlovid? Two, we believe at Protect Our Province BC that in 2023, it is more than time to update the definition of severe COVID outcomes. And then finally, we want to show that BC has the most restrictive access when it comes to Paxlovid eligibility in Canada. So let us start. So what do we know about Paxlovid? Now, I want to have a disclaimer that I have no affiliation whatsoever. I'm not funded, and I have no relationship with the company that makes Paxlovid, Pfizer. And in addition to that, throughout the briefing, I will be switching back and forth between the brand name Paxlovid and the other name, the generic name nirmatrelvir ritonavir. As you can see, it's a mouthful. So Paxlovid is more commonly used and known to everyone. And unless it's the title of a study, I'll be using most of the time the name Paxlovid. The second disclaimer I want to make is that I am not an epidemiologist, so I will provide a broad overview of some of the studies. The studies chosen give a good idea of where we're at, and in our opinion, they are some of the ground base for the knowledge that we currently have on Paxlovid and its effectiveness. But there will be more studies, and our knowledge will change, and it'll be up to us to adapt the use of Paxlovid as the information comes in. So the last thing I want to say is that this is really should be viewed as part one of a larger topic. So on Wednesday, March 1st, 2023, at 2 o'clock Pacific time, I'll be joined by Dr. Susan Kuo, who's a practicing physician in long-term care and in a family medicine private office. And she will share our experience up to date using Paxlovid and what we should all know and care about when it comes to Paxlovid. So let us get started. So Paxlovid is really a medication that is made up of two components. First, the active ingredient is nirmatrelvir. That is the compound that blocks the enzyme that is necessary for the virus to replicate, the virus SARS-CoV-2 to replicate inside our cells. In addition to nirmatrelvir, the other ingredient is ritonavir. And essentially what ritonavir does is it boosts the pharmacokinetics or the effectiveness of nirmatrelvir by reducing its metabolism and allowing nirmatrelvir to act for longer. Unfortunately, this part, ritonavir, is the one that has a lot of drug-drug interaction, as we will talk about more on Wednesday. So Paxlovid was approved by the United States Food and Drug Administration back in December of 2021. And it was followed a month later or so by Health Canada approval. In Canada, it's approved only for adults for the treatment of mild to moderate COVID-19 infection in individuals that are high risk of developing serious disease. In the States, in the United States, Paxlovid is approved in the pediatric population that is 12 years and older, and in those children that weigh over 40 kilograms. The way Paxlovid works by blocking the replication of the virus once it enters our cells makes it that it's most effective when it's used within 5 days of symptom onset. You can well imagine that if you wait too long, by then the virus has replicated and has left our cells to infect more of our body and organs and our bloodstream. So by that time, if we wait too long, Paxlovid will not be effective. And the reason I want to emphasize that is that there's a lot of misconception amongst both the public and providers that people should wait to see if they have a severe infection. That is not why Paxlovid is to be used. That's not how it should be used. Paxlovid needs to be used in individuals that are at risk of progression to severe disease, and it's got to be taken within 5 days. So it's approved for the outpatient use in the mild to moderate stage and within 5 days of symptom onset. I hope that's clear. Now, delving into some of the studies that I've identified, I want to reemphasize that I'm not an epidemiologist. So I will speak broadly about the studies, and I will give my two-bit in the issues or the limitations that I've identified. So starting with this study, it's called EPIC-HR, which means Evaluation of Protease Inhibition for COVID-19 in high-risk patients. First of all, it's a pharma-funded study. It's the Pfizer study that allowed Pfizer to go on to get FDA approval and then Health Canada approval. It was an international study involving multiple countries. It was a double-blind, randomized, placebo-controlled trial, and that is the perfect setting for having that type of design because it limits the amount of bias in terms of who's eligible and also in our interpretation, and it limits the confounding by additional factors that may influence the results. So this study compared Paxlovid versus placebo, and it looked at its effectiveness, its safety, and also the change in the viral load when it was used in the treatment, again, of mild to moderate symptomatic adults with COVID-19. They enrolled 2,246 adult participants, and half of them were treated with nirmatrelvir and half were in the placebo group. To be enrolled, you needed to be unvaccinated, have no prior infection, not be hospitalized, and be identified at high risk for progressing to severe disease. So anybody who'd been previously infected was excluded from this study. And the reason was that we wanted to see the effectiveness of nirmatrelvir, ritonavir alone without previous co-founder or covariable. The study took place during Delta, and that's important. The primary outcomes that they looked at in terms of effectiveness was preventing hospitalization or death from all cause within 28 days from taking the medication, or within 28 days of being enrolled, and with taking the medication within 3 days of symptom onset. I hope that's clear. So what were the results? What they found, and I'm showing the secondary outcomes here because it's more relevant to how we use Paxlovid within 5 days of symptom onset. And these results are nearly identical to the primary outcome, which was looking at the group that received Paxlovid within 3 days. So here what we see is relative risk reduction that was highly significant, 88%, in terms of hospitalization or death in those that took Paxlovid. And this was for reducing hospitalization or all-cause death through 28 days. They stopped counting at 28 days. And this was highly significant, and as I said, was the reason why the US FDA and then Health Canada approved Paxlovid in adults. It's worth mentioning that the median age in this population was 46 years old. And again, want to reemphasize that this was during Delta. So before I go on to talk about the other studies, let me set the stage a little bit here. So the original study looked at adults that were not infected, not immunized, and were high risk, and they looked at the effect of Paxlovid during the Delta wave. So now what happens when Omicron hits, when we are dealing with Omicron and its subvariants, and what happens when the population, many in the population have been vaccinated, many have been vaccinated plus infected. So the question becomes, how effective is Paxlovid now in this new context? And that's what the next studies I'm going to talk about looked at. Now, these were not double-blind randomized controlled trials, but rather they were more population cohort or real-life observational studies that used a healthcare database to look at the populations that actually receive Paxlovid, the adults that actually receive Paxlovid versus those that did not, and then look at what were their outcomes. You can well imagine that we're not comparing apples to apples here, because the people that are eligible for Paxlovid are completely different than the people that are likely not to get the treatment. So all of these studies use statistical methods or tools to try to make both population apples. And so that the both population that got treatment or not treatment could be comparable, and we could dissect out what was the effect of the medication alone without dealing with confounders, be it immunity, be it multiple medical risk factor, etc. And that is what each of the studies I'm going to talk about tried to do. Now, when you're looking at database, one of the things you don't have is, yeah, you can tell that somebody got prescribed Paxlovid, but you don't know whether they took it. And that is one of the blind spots to keep in mind here with these electronic health record or government database for these studies. What else? Let me just regroup here. I think that's it in terms, so we can talk about this study. This study was published in the New England Journal of Medicine. It was an Israeli study that tried to replicate the first original study that got Paxlovid US FDA approval. So it tried to replicate the EPIC-HR study. They looked at effectiveness in terms of hospitalization and deaths at 28 days. And they enrolled adults over the age of 40 years. And again, they were in the outpatient setting. And they were enrolled based on testing positive for COVID and being eligible to receive Paxlovid. The study used the Clalit Health Services electronic health records that covers about 50% of the entire Israeli population and covers about 2/3 of older adults. Again, it was during Omicron. It was early between January and the end of March of 2022. And they balanced the risk between the two groups, the treated and the untreated group. It was quite a large study population that they extracted. So over 109,000 patients met the eligibility criteria. However, in terms of who got treatment, only 4% of individuals, so just under 4,000 patients, 3,900 in the database during this time frame, receive Paxlovid. We don't know why, but it was quite a small percentage that in fact met treatment eligibility, or that received treatment, I should say. So the mean age of the participant was 60 years old, so quite older compared to the first EPIC study, where it was the median age was 46. And this population here, about 78% had some form of immunity. Granted, the way they define immunity was pretty basic. It was 2 doses or more of Pfizer. Israel used the Pfizer mRNA vaccine, or one previous infection, or hybrid immunity. That's how they define immunity. So again, 2 or more doses, a prior infection, or a combination of both. And we know now that for Omicron, immunity is really 3 doses of vaccination. And the primary outcome was hospitalization, and the secondary outcome was death from COVID-19. And that was within 30 days. So their result basically showed significantly lower rate of hospitalization and death in the group that was over 65 years of age. And that remained true whether people were had prior immunity or not. And again, highlighting that that definition of immunity was quite basic and would not meet today what we see as 3 dose being needed to be immune for Omicron. In addition to that, what they found is that in the group that was younger, in the 40 to 64 years old, they did not see any benefit in terms of lowered hospitalization or decrease lowered rate of death. It wasn't clear why this happened, and the authors certainly didn't have any good explanation for why this subgroup didn't experience benefit when it came to nirmatrelvir. And as you will see with the next study, this was not replicated in other studies. So some of the limitations for this study, like I said, for some reason, when they looked at the database, only 4% of people were treated. So it's a very small number, and it makes you wonder why. And in addition to that, this was not a double-blind randomized controlled trial, and though there is possibility for confounders or variables that get in the way of separating out the full effect of nirmatrelvir. And one of the ones that was brought up was the timing of the last vaccination, because we know now that if you are more than 20 weeks out of your last dose of the booster, your level of protection is significantly lowered than if you are closer to the date, closer to having received your booster. And again, this study didn't look at that. All right, so let's move on to the next study. This one was an American study, again, using an electronic database from the Brigham Mass General hospital in the United States. I should say that it was an NIH-funded study, and it was an observational data study that tried to emulate a trial, and they tried to randomize within their database, select individual on a random fashion that got Paxlovid. Again, it ran during Omicron from January 1st to July 17, 2022. And it used the electronic health records from Mass General Brigham. They enrolled over 44,000 non-hospitalized adults. And amongst this group, 90% had received more than 3 or more vaccine doses. So very different, again, from the first EPIC-SR HR high-risk study that I presented. And they included adults over the age of 50 who tested positive on PCR or on a rapid test. So what did they find? So what they found for this studies, they used the composite outcome of hospitalization within 14 days or death within 28 days of a COVID diagnosis. And they found that in this group, there was significant reduction by 44% in the composite outcome. And if you split it up as a secondary outcome, looking at each individual variables, you had a 40% risk reduction in hospitalization and a 71% risk reduction for death in their cohort of adults over the age of 50 that received nirmatrelvir. Need to emphasize that that cohort started from a very low admission rate. The admission rate was already quite low at 1%, but it was further reduced. I want to take a moment here to read one of the comments the researchers made about the study, because it's easy to say, oh, if you're only getting so few people admitted, what's the point of reducing even less the number of hospitalization and death? And really what the researcher said is that although these data suggest its clinical impact may be reduced in the context of high levels of prior immunity and consequent lower risk, the estimated risk reduction in hospitalization by 40% and death by 71% could have large population benefits if nirmatrelvir plus ritonavir is used widely. And this actually applies if you think about the first wave of Omicron back in February of 2022. At that time, we had a 7-day average of daily hospitalization in BC of 1,000. And the system was overwhelmed, and any further reduction in both death and hospitalization would have been highly welcome by our healthcare provider and our healthcare system. The other thing to emphasize in this study is that the benefits were seen across the risk strata. What varied, however, was the amplitude of the change. So essentially, you had increased protective activity among incompletely vaccinated patients who had received most recent vaccine, and those that were more than 20 weeks out. So it didn't matter the level of vaccination, you had benefits. Though obviously the biggest benefit were in people that were unvaccinated, and that was 81% risk reduction in this group. Okay, so that was true for vaccination. It was also true that the relative risk reduction was significant across age groups, comorbidity scores, and body mass index. So how do we put this all together? So what we can say is that in the age of Omicron, in a situation where less people are being hospitalized for COVID-19, more people have some form of immunity, be it infection plus vaccination or multiple dose of vaccine. There is still a role for Paxlovid. And it's particularly true when it comes to limiting in BC the amount of deaths that we've seen. If you look during the year 2022, we've had more deaths combined than in the 2 prior years. So Paxlovid still has a role to play. And it is, in our opinion, at Protect Our Province, BC, being underutilized. Where it becomes more murky is where do you get the biggest bang for your money in terms of using the medication. So what all these studies show is that there's a risk continuum for COVID-19 based on age. It's not black and white. Age remains the biggest risk factor, but adding to that are multiple variable risks based on immune status, based on medical conditions, based on vaccination status. And I added here that the time of the last booster matters. If you're more than 20 weeks out of your booster, we know that you're more prone to infection and your severe outcome can also start increasing. And the other thing that take into consideration when we decide who should be getting Paxlovid is the social determinants of health. We know that underhoused population are at high risk of COVID-19. We know that racialized communities have less access to vaccination, testing, and healthcare. And particularly in the States, the evidence is there to show that they have worse outcomes as well. So where does that leave us in terms of what should be the risk factors that we use and what should be the indications for the use of Paxlovid? We at Protect Our Province BC think that we need to update the definition of what severe COVID outcomes are. And we need to update what are the risk factors for using Paxlovid. We are in 2023. The elephant in the room that none of these studies have talked about is that outside of the 30-day acute mortality and hospitalization for COVID-19 infection, there is also mass disability that is happening with significant life-altering outcome in the form of long COVID or post-acute sequelae of COVID. And that's not being factored in to the severe outcome of COVID. We also know that mortality does not stop at 28 days post-infection. Professor Tara Moriarty has done a lot of work showing that there is significant excess mortality that is unaccounted by our BC public health when it comes to COVID-19 deaths. We know that COVID continues to harm and also kill British Columbians after 28 days. But many are not counted. So you may have a blood clot, you may have a heart attack, or you may have a weakened heart, a cardiomyopathy from COVID, and you may die after 30 days, and you may die with a second infection, and that's not being counted. So we need to look at what is the role of Paxlovid when it comes to these outcomes as well. In addition to that, we don't know who's at risk for long COVID, but a lot of people have declared themselves vulnerable. So anybody who currently has long COVID or anybody who's recovered from long COVID, the UK long COVID charity has shown that these individuals with reinfection are at heightened risk of relapse, somewhere in the order of 58%. So there is a role for preventing infections and protecting people that have long COVID and people that have recovered from long COVID. And that needs to be studied more. But one study has already tried to shed a bit of light into this. Admittedly, it is a preprint, but that is a large veteran affairs study out of the United States that again used database and looked at their their members, their veteran members that receive Paxlovid or did not receive Paxlovid during Omicron from March 1st to June 30th, 2022, and they did their follow-up until the end of August. And one of the things that they showed is that for post-acute sequelae of COVID, which is the same thing as long COVID or post-COVID complication, receiving Paxlovid, being treated with Paxlovid for a COVID infection, reduce the risk of post-acute sequelae of COVID by 26%. And that was significant, statistically significant. They looked at 10 out of 12 post-COVID sequelae. They looked at 12 post-COVID sequelae, but 10 out of 12 were limited or diminished by taking Paxlovid. 2 of them were not affected by taking Paxlovid with a COVID infection. And amongst these 10 were blood clots, the risk of developing blood clot, the risk of developing a cardiac arrhythmia, the risk of developing a heart attack, kidney disease, liver disease, fatigue, muscle pain, neurocognitive impairment, and shortness of breath. All of these were significantly diminished in individuals that received Paxlovid when they had a COVID-19 infection. So it needs to be repeated by other studies, and we also need to wait for the final publication. But this group out of the United States has done a lot of studies, and all of them ended up being published. And right now, with the limited treatment that we have for long COVID, it's important that we start looking at preventing long COVID and preventing relapse as a role for Paxlovid to play. So with that being said, I wanted to show 2 minutes of this video, and you will hear from Dr. Akiko Iwazaki, who is a Yale immunologist and a strong advocate and researcher for long COVID. So video, please.
For someone who's newly infected, I would definitely recommend to get the Paxlovid right away, because the earlier the treatment, the more likelihood of you being able to eliminate the source of viral reservoir. And actually, treating early with Paxlovid or monoclonal antibodies is just, in general, great to avoid any of these 4 hypotheses of diseases from occurring, because the longer you allow the virus to replicate and cause damage, the more likelihood of you triggering these 4 types of disease outcomes. And there is even a study that suggests that getting vaccination within the first 12 weeks of infection reduces risk for developing long COVID.
After my second vaccine, my long haul symptoms started to ease up, which I guess happens to like 40% of long haul patients. But I still have shortness of breath sometimes, and heart palpitations and tingling in my hands. And it'll come out of nowhere, you know, and it's scary when it happens.
So even vaccination may be helpful during the early phase of infection. But if you wait too long, these things aren't going to be effective. I'm personally surprised that long COVID isn't at the center of discussion in public. Knowing how devastating this disease is, I am very hesitant myself to go out there and get exposed to any kind of COVID. I just think it's really gambling with your health, and it's not safe. I personally think that removing precautionary measures to prevent transmission is a very bad idea. I do absolutely ensure that my children are fully vaccinated, boosted if they're eligible, and are wearing masks inside while they're going to school or elsewhere. We need to layer protective measures one on top of the other in order to reduce the risk of getting COVID so that we don't get long COVID either.
So we've talked about Paxlovid, what we know. We're suggesting at Protect Our Province BC that we need to address the elephant in the room, and we need to look at Paxlovid as also a way of limiting long COVID. And we need to particularly protect individuals that have recovered from long COVID and those that are still suffering from long COVID, so that if they get reinfected, they don't suffer a relapse. So the use of Paxlovid needs to be looked at in 2023 outside that 28-day window of reducing hospitalization and death. That's happened beyond 28 days as well. So where are we at now with access to Paxlovid in BC? Well, BC has the most restrictive access when it comes to eligibility for Paxlovid treatment when you're infected with COVID. Thanks to our savvy reporters, we know that as of early January 2023, there were about 140,000 courses of Paxlovid sitting on shelves being unused in BC. Now, what's even more egregious is that when you look at BC's own data, this is BC CDC weekly report, the last one that was available. So when you look at in the 28-day outcome measure in terms of deaths from COVID, people that are dying from COVID in this province include the elderly over the age of 80. But in addition to that, the other high-risk group in the acute phase post-COVID are the people in the 60 to 79 years of age group. If you look at the third graph from the top. Now, if we are intentional about wanting to decrease hospitalization, if you look at the top graph of hospitalization, the blue line represents the 60 to 79 years old. And this group is actually quite similar when it comes to 7-day average count for COVID hospitalization. And then worse still is if you look at the ICU rate of hospitalization in people who have acute COVID. The group, the 70 to 79-year-old, the blue line, surpasses the older group in 80 and above. And that is true also when you look at the cumulative case counts of how many 60 and to 79-year-old have been admitted to the ICU versus other age group. They are leading the pack. So BC's own criteria suggests that using 70 as a cutoff for vaccinated, non-immunosuppressed individuals to be able to receive COVID-19 is not the right age. And that age should be decreased at the very least with their own data down to 60. Now, we're suggesting going further down so that BC aligns more with some of the other provinces and territories in Canada, because right now BC is the province that has the least accessibility when it comes to eligibility criteria for Paxlovid. Thus, close to 140,000 treatment course sitting on shelves. So we urge government to revisit the Paxlovid eligibility criteria and expand the severe outcome to include long COVID, and as well as expand in the population at risk anybody who has long COVID, either now or has recovered. These people need to be protected. They've shown that they're at high risk. I think this is where I want to stop right now, and I want to thank you for being with me today. The only other plug I'd like to add is on Wednesday, we will be talking with Dr. Susan Kuo, who works in BC in family practice and works in long-term care, where there are continuing to be recurrent COVID-19 outbreaks. And because of that, Dr. Kuo has a lot of experience prescribing Paxlovid. And we think the public needs to know about the medication because they're going to need to push providers and public health officials to release the access of Paxlovid to people that are infected with COVID going forward. So thank you.